How's it going, everybody? Welcome back to another episode of Pathagonia. This is Cole. So today I'm going to talk a little bit about testicular tumors. Recently I just came off surgical pathology, and one of the more interesting cases that I had that block was a mixed germ cell tumor, which we'll get into a little bit more what exactly that means. So the first category that we're going to talk about of testicular tumors are germ cell tumors. So there's three main subtypes depending on age and if they are derived from germ cell neoplasia in situ or GCNIS. The most common is germ cell tumors derived from GCNIS, the postpubertal type, or type 2 below, which is often subgrouped into seminoma and non-seminoma germ cell tumors. Although only 1% of male cancers, they are the most common cancers among young men between puberty and the age of 40 or 40s. So some risk factors for testicular tumors include family history, cryptorchidism, subfertility, pesticides, marijuana, and microlithiasis. Although they can be aggressive tumors with current treatments, they can often be cured as they're very responsive to chemoradiation. So the three main subtypes that we're going to talk about, well, there's several types that we're going to talk about, but the three main subtypes are below: type 1, 2, and 3. Type 1 would encompass teratomas, yolk sac tumors, dermoid cysts. Type 2 encompasses seminomas and Embol Carcinoma, Corio Carcinoma, yolk sac tumor, mixed germ cell tumor. And type 3 is the spermatocytic tumors. So we're going to go a little bit more into each of these entities further on in the video. Something I do want to point out, as mentioned above, this type 2, these are germ cell tumors derived from germ cell neoplasia in situ, which are all of these. And I also want to point out in the genotype section that these entities often have overexpression of isochrome 12p. So just a molecular tie-in to be aware of for practice, for testing purposes. Yeah, so next entity, and I really like how Kurt's Notes does this. He always has these excellent mnemonics and things to think about. So for a seminoma, you want to think clear or white color. So just glancing at the photos, we see a lot of white and cleared out areas. So seminoma is the most common germ cell tumor. About 50% of testicular tumors or germ cell tumors are seminomas, and they will present with a mass, usually unilateral. Grossly, it's going to be solid, fleshy, lobulated, and cream colored in the grossing room. You're going to have large polygonal cells with clear to eosinophilic cytoplasm, full of glycogen, which is what's causing that white, clear color, with distinct cell membranes, vesicular chromatin, and prominent nucleoli. You're going to see fibrous septae and nested architecture with lymphocytic infiltrate. Sometimes you'll see granulomas and GCNIS, usually in the residual tubules. Rarely you can see syncytio trophoblasts, so as you would imagine, you could have some elevation in the serum HCG or even some staining with HCG if you were looking for a Corio Carcinoma component, because seminomas rarely can have a syncytio trophoblasts in them. So for IHC for a seminoma, it's going to be OCT34 positive, CD117 or c-KIT positive, D240 and SAL4 positive. You're going to have elevated serum LDH, rarely HCG as mentioned, and the first site of metastases are often to the retroperitoneal lymph nodes. A little molecular again, as previously mentioned, the majority of seminomas have isochrome 12p and c-KIT mutations in many. The prognosis is good if treated. So good one to know. Think clear, white color, seminoma. I've also heard fried egg cell, which kind of helps me. Fried egg cell for seminoma or dysgerminoma in the ovary, or even oligodendroglioma in the central nervous system. Next up, we've got embryonal carcinoma. So for embryonal carcinoma, you want to think purple color. We've got this purple shape here, and then if we look at our images, just at low power first glance, it definitely looks very purple to me, just kind of a gestalt. So embryonal carcinoma are the second most common testicular germ cell tumor. They're usually part of a mixed germ cell tumor with rudimentary epithelial differentiation. There's large, crowded, primitive pleomorphic cells and vesicular nuclei with prominent nucleoli. There's coarse basophilic chromatin and amphiphilic cytoplasm. You can have variable architecture in embryonal carcinomas with nests, sheets, papillae, and glands, and prominent mitoses and apoptotic bodies. So for IHC, just like seminomas, they're going to be OCT3/4 positive. However, distinctly, they're going to be CD30 positive for embryonal carcinoma. They will also be positive for AE1, AE3, and SAL4. Same molecular, as mentioned before, isochrome 12p amplification, and these are often aggressive, but they do often respond to chemotherapy. So this is what an embryonal carcinoma would look like. And moving on. So for Corio Carcinoma, you want to think red color. Corio Carcinoma is usually part of a mixed germ cell tumor with malignant cytotrophoblasts and trophoblasts, mononuclear with light cytoplasm, and syncytiotrophoblasts or multinucleated with deeply eosinophilic cytoplasm. And you're going to see abundant hemorrhage, grossly and even microscopically. For choriocarcinoma, you want to think red, hemorrhage. It's kind of a bloody tumor. For IHC, it's going to stain for HCG. The syncytiotrophoblasts will be positive for inhibin and glypican-3. Cytotrophoblasts will stain with SAL4, P63, and GATA3. So in the lab, if this patient gets some labs drawn, you may see very elevated serum HCG in choriocarcinoma. Similar to LH and TSH, can lead to gynecomastia and thyrotoxicosis. So choriocarcinoma is the most aggressive germ cell tumor with frequent hemorrhagic metastases and the least responsive to treatment. All right, next up we've got yolk sac tumor, or postpubertal type. All right, next up we've got yolk sac tumor, postpubertal type. So for this entity, you want to think pink in color. Yolk sac tumor, also known as endodermal sinus tumor, or YST for yolk sac tumor. This is almost always a component of a mixed germ cell tumor. There's many patterns and architecture, can often be combined patterns. The most common pattern or architecture is reticular or microcystic, or like a honeycomb meshwork. Can also be solid, papillary, glandular, and often have hypocellular myxoid areas. Classically for yolk sac tumor, you're going to see Schiller-Duval bodies and refractile eosinophilic hyaline globules, as shown down here below, and band-like intercellular basement membrane material. So here's a nice example of a Schiller-Duval body, maybe even one up here. And you can have hepatoid areas resembling liver that stains with liver markers. So for IHC, for yolk sac tumor, it's going to be positive for alpha-fetoprotein, glypican-3, SAL4, AE1, AE3, and unsurprisingly, you're also going to have an elevated serum AFP, alpha-fetoprotein. So post-chemo, you can get sarcomatoid yolk sac tumor as well, so good to be aware of that. Next entity, we have teratoma, postpubertal type. So this is composed of tissues from one or more germinal layers may be composed of differentiated mature tissue or immature embryonic type tissue. It's often part of a mixed germ cell tumor. So in contrast to the ovary, pretty much all teratomas and post-pubertal testes are malignant. You can see virtually all tissue types, including epithelial and mesenchymal, and it's often multiple cysts lined by glandular or squamous epithelium with frequent immature neuroectodermal structures. For IHC, you can have differentiated elements express profile of that tissue type, and there's often areas of cytologic atypia, including primitive mitotically active stroma cuffing glands. If a dysplastic component forms a nodule that is larger than a 4x field, or 5 millimeters, then this could be a somatic type malignancy arising in a teratoma, usually a sarcoma, most commonly rhabdomyosarcoma. Most common component in a treated germ cell tumor is a teratoma. In a rare situation where it can be benign teratoma in an adult is dermoid cysts or organoid morphology with prominent components of ciliated epithelium and smooth muscle, and no GCNIS, isochrome 12P, or testicular scarring. Next up, we've got a mixed germ cell tumor. So these are malignant tumors with more than one germ cell tumor component, as the name suggests. Clinically, they're regarded as non-seminoma, even if seminoma is present. And the majority of all non-seminomatous germ cell tumors are mixed, so you must report approximate percentage of each component. For example, I recently had a case and it was 65% embryonal, I believe 20% yolk sac tumor, and 15% Corio Carcinoma. So in the synoptic or in the report, you want to include the approximate percentage of each of those components, for which IHC will be quite helpful in delineating that. So of note, since cystiotrophoblasts do not equal choriocarcinoma, they can be seen in other tumors. Like we previously mentioned, they can be seen in seminomas. So some special subtypes to know for mixed germ cell tumors are polyembryoma, which is a combination of embryonal carcinoma and yolk sac tumor resembling an embryo, and diffuse embryoma, which is orderly combination of embryonal carcinoma and yolk sac tumor in parallel flat layers. So the next entity we'll talk about is a regressed germ cell tumor. So these are germ cell tumors that have undergone either partial or complete regression. So they're kind of burnt out, you could think of it as, leaving behind a well-delineated nodular focus of scarring fibrosis in the testis. They can present with metastatic disease, but primary has completely regressed. These can be seminoma or non-seminoma, and some of the scar findings that you may see are well-demarcated scar, coarse calcifications within tubules, chronic inflammation, and hyalinized tubular ghosts. Some nearby findings, you may see GCNIS, tubular atrophy, or microliths. All right, next up we've got spermatocytic tumor. So these are relatively rare with generally an excellent prognosis. These are not associated with GCNIS or cryptorchidism, and they are not a component of mixed germ cell tumor. They usually occur in older men over 50 and have a polymorphous cell population, so 3 cell types, small, medium, and large, poorly defined cell membranes, dense cytoplasm, round nuclei with dense to granular chromatin, and diffuse to multinodular pattern of growth. There's a frequent cystic change or edema that may occur, and there's no significant inflammation or granulomas. For IHC, there's negative for usual seminoma markers such as OCT3/4, but spermatocytic tumors do stain positive for c-KIT or CD117 and SAL4, and they can undergo sarcomatous transformation. And this is what a spermatocytic tumor may look like. All right, next up we've got teratoma, prepubertal type. We already talked about the postpubertal type, and now we'll talk about the prepubertal type. So these are composed of elements resembling somatic tissues from one or more germ cell layers. And these primarily occur in prepubertal males under 6 years of age, but they can be seen in older patients as well. So in contrast with postpubertal type, prepubertal teratomas have benign behavior. They do not recur or metastasize, and there's no association with GCNIS or isochrome 12P amplification. There's no cytologic atypia and no association with mixed germ cell tumors. As such, they are most akin to the mature cystic teratomas seen in the ovary. Prepubertal type teratomas frequently include skin structures, ciliated epithelium, fat, cartilage, bone, and muscle and organoid structures. And there is no significant cytologic atypia. So there is some normal surrounding testicle with no GCNIS, tubular atrophy, scars, microlithiasis, necrosis, or impaired spermatogenesis, which might suggest a GCNIS-derived germ cell tumor. So some specialized variants of teratoma prepubertal type are dermoid cyst, which can replicate skin in an organoid arrangement, squamous epithelium with adnexal structures, and this is typically cured by excision. Also, you can have an epidermoid cyst, which is a unilocular cyst with squamous lining and keratinaceous debris, no adnexal structures or other elements, also cured by excision. And you can also have a well-differentiated neuroendocrine tumor with similar morphology to elsewhere in the body, where you can see those, often pure, usually have good behavior, and only variant that can behave aggressively. We also have a prepubertal type yolk sac tumor. So these are rare, usually in young boys under 6 years old. They're identical morphology and IHC profile to the postpubertal type. They secrete AFP. However, unlike postpubertal yolk sac tumor, they are not associated with GCNIS. There's no isochrome 12P amplification, and there's excellent survival even with advanced stage. So prepubertal type yolk sac tumors are usually pure, but can be seen in combination. Mixed teratoma and yolk sac tumor, prepubertal type, are commonly seen together. So this chart I'm going to allow you to kind of just review on your own. Many of the IHCs I already mentioned when we went through each of the entities, but this is a good chart to review because it goes through all of the entities that we've already discussed, as well as other tumors in other systems and elsewhere in the body that can also stain for these IHCs. So I know in my first and second year, I still spend a lot of time going over IHCs. It's a very important kind of a language to learn of pathology, and it's good to take the time early and often to review various IHC patterns. So I'm not going to read through all of this. I think it would be higher yield to reference it on your own. All right, moving on to our next category of testicular tumors. We just went over germ cell tumors. Now we're going to talk about sex cord stromal. So in general, these are rare. They're more common in kids, and the vast majority are benign. There's a little variable, but often stain with some combination of inhibin, calretinin, SF1, FOXL2, and melin A. So first up, you have Leydig cell tumors. So for Leydig cell tumors, you're going to see abundant eosinophilic granular cytoplasm with diffuse growth, uniform round cells, round central nuclei with prominent nucleoli, and frequently you're going to see these Ranke crystals. So these Ranke crystals, very testable, commonly associated with Leydig cell tumors. These are usually asymptomatic, but children can present with precocious puberty as the tumor can secrete steroid hormones, testosterone. And that's because the Leydig cells are the cells in the testicle that produce androgens or testosterone. The way I remember that, I think of lions, and lions have their manes, which is a secondary sexual characteristic for lions, likely in the males, caused from production of testosterone. So I think of Leydig cell, lions. Those are the types of cells that produce testosterone. So this is the most common testicular sex chord stromal tumor. The vast majority are benign. So next up, we've got Sertoli cell tumor. Sertoli cell tumors often show at least focal tubular differentiation. Usually there's moderate pale cytoplasm and rarely diffuse growth. They kind of have a unique IHC, which is frequent nuclear beta-catenin expression, WT1, CK, AE1, AE3, and neuroendocrine markers. The vast majority of Sertoli cell tumors are benign, and there is a variant, which is sclerosing Sertoli cell tumor, which you can have extensively hyalinized stroma, as shown below, with cells arranged in tight cords and clusters. So some factors associated with malignant behavior in sex chord stromal tumors include cytologic atypia, abundant mitoses, large size, vascular invasion, necrosis, and infiltrative growth. And as noted, these are pretty common sense bad findings in general in pathology. If you're seeing cytologic atypia, a bunch of mites, vascular invasion, necrosis, infiltrative growth pattern, usually not a good sign as far as malignant potential. Next up, we've got granulosis cell tumors. So these are similar to the more common ovarian counterpart. You can have an adult granulosis cell tumor. These are rare, often asymptomatic, but they can secrete estrogen. As far as cells, you're going to have scant, pale architecture with grooved nuclei, or I've heard coffee bean nuclei. There's going to be varied architecture, sheet-like, trabecular, ribbon-like, microfollicular, with Call-Exner bodies filled with pink secretions. So molecularly, granulosis cell tumors frequently have a FOXL2 point mutation, and you can also have juvenile granulosis cell tumors. These are rare. Almost all occur in the first decade, as the name juvenile would suggest, often before 6 months of age. They usually present as a mass, and there are microfollicles with mucinous secretions, round nuclei with no grooves. So here you might be able to see a Call-Exner body, and you can kind of make out some of the cytology in the grooves, coffee bean nuclei or nuclear grooves of the adult granulosis cell tumor. All right, next up we've got large cell calcifying Sertoli cell tumor. As the name suggests, you're going to have large Sertoli cells with abundant granular eosinophilic cytoplasm. You may have calcifications, focal, pseumomatous to large, plaque-like. There's going to be often a prominent neutrophilic infiltrate, and you're going to have no nuclear beta-catenin. So large cell calcifying Sertoli cell tumors are frequently associated with Carney complex and frequently have a PRKAR1A mutation. So some other tumors to be aware of, you can have intratubular large cell hyalinizing Sertoli cell neoplasia, which is expanded seminiferous tubules with large Sertoli cells with pale cytoplasm, accompanied by prominent basement membrane deposits around and within the tubules. So these occur almost exclusively in Peutz-Jeghers syndrome. Think like SCTATs, but with a more complicated name. and they often present as prepubertal males with gynecomastia, as aromatases made by the tumor convert androgens to estrogen. And these are always benign. So for Peutz-Jeghers, think very complicated names. So you have sketats in females, and intratubular large cell hyalinizing Sertoli cell neoplasia in the testes. You can also have a fibroma or a thecoma. So these resemble their ovarian counterparts. They're benign, they're rare. You're going to have unencapsulated proliferation of spindled cells with scant eosinophilic cytoplasm. So the next category are just kind of some miscellaneous tumors of the testes. And first up, we've got Ganantblastoma. So these are made up of germ cells resembling GC&IS cells and spermatogonium, sex cord cells resembling immature granulosis cells, and they're going to be arranged in round nests with round deposits of eosinophilic basement membrane, and frequently they have calcifications. So Ganantblastomas develop in individuals with gonadal dysgenesis, and they can progress to a germ cell tumor, often seminoma. Important to know, you also can have hematolymphoid tumors. So this is the most common testicular tumor in men over 50 years old. They can be primary or part of systemic involvement, and they often obliterate the seminiferous tubules centrally with peripheral intertubular spread. Diffuse large B-cell lymphoma comprises about 90% of primary testicular lymphomas. It's also very prevalent in the breast. And the same stains are used for these lymphomas as are elsewhere in the body. So some other tumors to be aware of, you can have ovarian type epithelial tumors. These resemble the entire spectrum of ovarian type epithelial tumors, most commonly serous and mucinous, with most being serous borderline tumors, which do not recur or metastasize. You can have a reedy testis adenoma. These are very rare. A benign tumor of the reedy epithelium that spans the spectrum from packed tubules, adenoma, to tumors with a cystic component, cystadenoma, papillary architecture, papillary cystadenoma, or glands with prominent fibrous tissue, adenofibroma. So for reedy testis adenocarcinoma, these are very rare. However, as the name suggests, they are malignant and are a diagnosis of exclusion, where you're going to have malignant gland forming tumor of the reedy epithelium, and it must be centered in the hilum of the testis. Patients must have no other similar primary, and other diagnoses, such as mesothelioma, must be excluded, and these typically have a poor prognosis. Lastly, of the other tumors category, you have a myoid gonadal stromal tumor. So this is a spindle cell tumor near the reedy testis with features of gonadal stroma and smooth muscle. And it's going to be circumscribed with densely packed spindled cells arranged in short fascicles. And for IHC, it's going to be positive for SF1, FOXL2, SMA, and S100. So the next category that we'll go into is paratesticular tumors. Firstly, we'll have adenomatoid tumor. So an adenomatoid tumor is a benign mesothelial tumor. It's the most common neoplasm of the paratesticular region, often based in the epididymis and less than 2 centimeters in size. So histologically, you're going to see irregularly shaped gland-like microcystic spaces composed of flattened or cuboidal cells with associated fibrous stroma and lymphoid aggregates with bland cytologic features. So a helpful feature is thread-like bridging strands, as shown here. And sometimes you can have signet ring-like vacuolated cells. These are adenomatoid tumors are typically solitary and localized. And for IHC, you're going to have mesothelial markers, so D240, calretinin, WT1, CK56, and they also stain with cytokeratin AE1, AE3. Next up, we've got mesothelioma. So mesothelioma is a rare malignant proliferation of mesothelial cells arising from the tunica vaginalis. So the mass envelops the testicle, often invading it. So like in the pleura, there's variable appearance of mesotheliomas in the paratesticular space. They're often epithelioid with papillary or tubulopapillary architecture, less associated with asbestos, and for IHC, you use the usual mesothelial markers that we just mentioned. So the next entity is papillary cystadenoma of the epididymis. So these are rare, benign tumors of the epididymal ducts, associated with von Hippel-Lindau syndrome, but is more often sporadic. You can have cystic structures that are focally papillary, with clear columnar cuboidal cells with abundant clear cytoplasm. There's frequently reverse nuclear polarity with colloid-like secretions, and morphologically and immunophenotypically, these resemble papillary clear cell renal cell carcinoma, which you can review our kidney tumors video to review that entity. So you can also have adipocytic tumors. So you can have a lipoma, just like elsewhere in the body. These are benign, most common mesenchymal tumor of this region, and they consist of entirely mature adipocytes. You can also have a well-differentiated liposarcoma. So this is a common paratesticular sarcoma. They often recur but won't metastasize unless they dedifferentiate. Histologically, you're going to see a varying proportion of adipocytes, fibrous bands with enlarged hyperchromatic stromal cells, and occasional lipoblasts. You can see inflammation or myxoid change, and giant marker and or ring chromosomes, and you will see that MDM2 amplification in a well-differentiated liposarcoma. If it's large or questionable atypia, consider getting FISH to help differentiate and to help fish or find that MDM2 amplification. Also, you can think about smooth muscle tumors like leiomyoma. These are benign, somewhat common. They consist of entirely bland smooth muscle, like in other locations, classically the uterus. You can also have leiomyosarcoma, which is a common paratesticular sarcoma with fascicles of spindled cells with brightly eosinophilic cytoplasm and cigar-like blunt nuclei. In a leiomyosarcoma, you're going to have significant atypia, mitoses, and or tumor necrosis. For IHC, it's going to stain for desmin, SMA, H-caldesmin, and calponin. Next up, we've got skeletal muscle tumors. So for this, you want to think about rhabdomyoma, which is benign and very rare, most often occurring in adolescence, and also rhabdomyosarcoma. So these often occur in children or young adults, and embryonal subtype with primitive round or spindled cells and variable eosinophilic rhabdomyoblasts with abundant eccentric cytoplasm. They often have a good prognosis, and for IHC, you're going to stain these with MyoD1, myogenin, and desmin. So lastly, just to wrap up this video, there's a couple pages of algorithms for diagnosis of these testicular tumors, and these are based on the reference listed here. So I'm not going to read the entire algorithms to you, most of which we kind of went through earlier in the video. But let's say you're on surgical pathology and you have a malignant testicular tumor case, and you want to work it up with the appropriate IHC and assess the architecture in a certain way. I would suggest referencing this algorithm. You can make flashcards out of it or just use it in your practice. But the more we use this, the more that we work up these entities, the more second nature it's going to become to make these proper diagnosis for our patients and ultimately get them the care that they need. So these algorithms are broken up into clear cytoplasm entities, glandular and or tubular growth, microcystic, and pink cells with abundant cytoplasm or oxophilic appearance. And there's also spindle cells. So when you're working these entities up, make sure you assess the architecture, the cytology, and then see which category your tumor falls into, and then use this algorithm to get to the correct diagnosis. So thank you so much. I know it was a long video, but it's an important topic and one that I still am trying to learn more about every day. So I hope you enjoyed, and I appreciate your support, and have a good day. Thank you.